All right, so we're going to go ahead and get started. We have quite a bit to cover today, and I want to hopefully leave a little time to get into any of your questions that I don't cover in the main presentation. I'll tell you right up front, my title is a little bit misleading because it implies that those are mutually exclusive things, getting the vaccine or getting sick, and that's not true, but I was looking for something catchy, and Dr. Salas helped me with that title. So we'll get into that more as we go along. For those of you I don't know, I'm Megan Borror, the Assistant Professor of Molecular and Cellular Biology here at OLLU. I'll give you a little more of my credentials as to why I'm giving this presentation to you as we get a little farther in. All right, I just want to give you an outline of the questions I'm going to cover so that you're not sitting there wondering, is she going to, your favorite question that you want answered, am I going to get to it? So just a little outline. First, we need to cover what a vaccine is and how it works so we can understand the rest of it. How are the ones that we have available to us different? How do they calculate those efficacy numbers? What about the testing? For the mRNA vaccines and others, was it rushed? What's the difference between emergency authorization and full approval? What about the side effects long-term? And then, does the immunity last? With the Delta, what's happening there? Is it going to work? And then lastly, some issues that have been brought up about fertility and pregnancy and those sorts of things. So those are the things I'm planning to cover. We'll hope we can get through them in an hour. So excuse a little bit of language in that graphic, but before we get started, I just want to make a note about sources and where you're getting your information from. So this graphic is kind of illustrating an issue that we've been dealing with for the past year and a half, where the experts say one thing and people online are going crazy. I even just noticed I saw the city of San Antonio announcing a vaccine clinic, and I on Facebook, and I clicked on the comments, and I shouldn't have. So everyone thinks they're an expert so far. So make sure your source has expertise. So the reason I'm giving you this presentation today, I have a PhD in microbiology, which encompasses bacteria and viruses. All of my research for my PhD, that's 6 years worth, was all in the field of virology. I did not work on respiratory viruses, but I do have some background in virology to be able to give you some insight into some of these questions. So people that have more expertise than me are scientists that study respiratory viruses, infectious disease specialists, immunologists, epidemiologists, and epidemiologists study pandemics and things like this, how viruses spread through a population. So look for those people. I don't expect everyone to be looking and reading through all of the original studies from those groups. They can be dense and it just takes a lot of time. I don't even have time to read through all of those myself. So what you want to look for in your news sources are they using data to back up their claims? There better be someone with expertise in that news source, and there better be some data that they're using to back up what they say. I know we all have this, you cheer for the underdog, you have 100 people saying one thing and one person goes against it, and you're like, oh, we should get behind that person. That's not the case here. They better, if you're going to go against what the majority of scientists are saying, they better have some data to back it up. So look for those things. All of my slides have sources for you. It's a mix of original studies as well as news sources. And hopefully we can make this presentation available to you like on SharePoint or something so you can go back and click through those. Things to be aware of: bias, especially political bias right now, either direction. Be aware of the news sources you're looking at and what kind of biases they have. We all have them. We've just got to be aware of them so we can kind of work against that. Be aware of things that are not published yet. So they would call them preprints. They've made them a lot more available to us because trying to get information out fast with COVID. So I just saw a thing today where they're talking about the new Lambda variant that's going crazy in South America. There are some studies out. They're not peer-reviewed yet. They're called preprints. They're not published yet. So you just got to be cautious of those. And as always, anecdotes. So, my brother's, neighbor's friends, so-and-so had this experience. It doesn't make their experience untrue. It obviously happened to them that way. However, it doesn't mean it's true for the general population. So those things I just want you to be aware of as you're looking at sources beyond this. All right, so before we get into what a vaccine is, we got to first talk about what happens during a virus infection, because those two things are related. So when there's a virus infection, a new virus invades your cells, the immune system, it will recognize it, but usually it recognizes it after the virus has gotten in, started causing some damage, started causing some disease. Okay, so once it starts doing those things, the immune system recognizes that it shouldn't be there, and then it can get rid of it and make a memory. Okay, you can think of the memory it makes kind of like a mugshot. Okay, so they're remembering what that virus looks like. You have cells and antibodies both that are remembering what that virus looks like, and then they can fight against it. So if the virus invades again, right, you get exposed to that virus again, the immune system already knows what it looks like. It catches it before it can cause damage again, and get it out of there. You wouldn't even know you were even exposed to it again. So that's kind of the natural progression of a virus infection. And the key here is this middle part where it's making a memory. I don't know, yeah, you can see my cursor there, hopefully. It's making a memory, it's making that mugshot so we can find it again. So now what do vaccines do? What vaccines are going to do is help your immune system make that memory, get that mugshot, without causing any damage from infection in the first place. So vaccines contain a piece of the virus. Now, different vaccines do it different ways. So not all vaccines are made using just a piece of the virus, but all of the COVID ones are. So we're gonna stick with that. Just a piece of the virus, and that's going to help the immune system make that mugshot. So basically, that piece of the virus is recognized by the immune system. Now they're going to know what it looks like, but that piece of the virus can't do anything. It doesn't replicate. It doesn't cause damage to your cells. It's just helping your immune system know what it looks like before you would encounter the whole virus. Now your immune system can remove that virus before it causes damage and disease. So you can imagine, say we had a room just packed full of people here, right? Standing room only, packed full of people. Maybe we got some security around the event, and there's a pickpocket in the room, okay? We'll go with that. You can go more gruesome, but let's keep it a little lighter, okay? There's a pickpocket in the room. We don't know it until it gets caught in the act, right? That person that's pickpocketing gets caught in the act, and they can remove it. At that point, they've stolen, how many wallets already. If you have a mugshot, you know what that person looks like. Security's going to stop them at the door. They're not even going to let them into the room. Same thing here, okay? The immune system can stop that virus before it gets in and damages it, as long as they know what it looks like ahead of time. Any questions so far? Okay. Like I said, text that number, people online, if you've got questions, and we'll keep going. All right, so the ones that that we have available, how are they different? I'm going to focus on the Pfizer, Moderna, and Johnson & Johnson vaccines. Those are the ones that are most readily available to us here in the United States. Here I've got them all listed, and then along the left-hand side, I've got the kind of the types of molecules and the more specifics here in the chart. So the piece of virus we're using for Pfizer and Moderna, a lot of these things in these two columns are nearly identical. So they're very much alike. Johnson & Johnson is a little more different. So the piece of the virus that we're giving in the vaccine for Pfizer and Moderna, it's an mRNA that has instructions for making that spike protein. Over here on the right-hand side is a picture of the virus. These red ones on the outside, this is what's considered the spike protein. It's just kind of a generic name for it, the spike protein that sticks out on the outside. That is what the immune system would recognize first. Okay, so in a natural infection, that's what the immune system is going to see and recognize first to be able to make that mugshot. So that's what we're giving it. Johnson & Johnson is similar, but they're using DNA for that spike protein. But all three of those are going to allow the cells to make that spike protein so that then the immune system can recognize it. The method of delivery for Pfizer and Moderna, lipid nanoparticles. Lipids, just another word for fats. So we need a way to protect this, to get it inside the cell safely and inside the cell without causing an immune reaction. So think of it like a little bubble of fat, and you got the mRNA inside. I didn't list all the different lipids they use. They are slightly different from Pfizer to Moderna. I gave you an example of one here because they're not going to mean a whole lot to you if you're not an organic chemist. I do want to point out, look, this is a long name, right? 1,2-disteryl SN glycero 3-phosphocholine. There's a thing in our culture right now that says to, be afraid of things you can't pronounce. Okay, that's ridiculous. If I gave you the list of molecules that are in a banana, you would not be able to pronounce half of them. Okay, so the only reason this has a funky, crazy name is because if I gave this name to Dr. Mungia and I gave it to a scientist in Germany and a organic chemist in Japan, they could all look at the same name and they can draw out that structure for you. They know exactly what molecule that is, what it looks like. So just don't let that throw you off. Additionally, the word nanoparticles. I know I've had some relatives that are very scared of that word. Nano just means small. Okay, that's all it is. It's not a microchip. It just means it's really small. Small pieces of fats that make up this bubble. Okay, so don't let those things throw you off. So that's what's around the outside of this vaccine particle. Johnson & Johnson does it a little bit different. This is actually a more traditional way that Johnson & Johnson uses, and they're using another virus. They're using an adenovirus. Adenoviruses mostly cause common colds. So they're taking the adenovirus shell, the outside of it, so kind of think about something similar to this, taking the adenovirus shell, taking all the guts out of it, doesn't have any of the stuff inside that's going to cause a cold, and then they're putting the vaccine into that. It's just a good way to get inside the cell. That adenovirus already knows how to get into cells. It can deliver it pretty easily. Okay, so that's a tried and true method. It's used for other types of vaccines as well. So those are our methods of delivery, how we're going to get it into the cells. We have to have buffering molecules. These molecules need to be kept at a certain pH to hold their shape and their structure. So buffering molecules like salts and some acid and base buffering systems are in this category here. Sugar helps maintain the shape of the molecule when freezing. The reason we need to freeze it is mRNA is very, very fragile. It has to be frozen pretty cold to keep it from just degrading. DNA, not quite as fragile, but still we want to maintain that shape. We don't want it to be affected. So that's what the sugar does. This is normal table sugar you can use here, also, although very pure table sugar. And then there's a different type of sugar used in the Johnson & Johnson. And then there's a few other extra ingredients in the Johnson & Johnson one. One thing we do not have to, or three things we don't have to worry about. These vaccines do not contain preservatives, okay? So sometimes those people get nervous and worried about those. There aren't any preservatives in these vaccines. So they're keeping them very, very cold, and that's what's helping keep them from going bad. There aren't any adjuvants. An adjuvant is just, you think of it like an immune system activator. So sometimes the vaccine itself doesn't give you enough of an immune response for it to provide immunity. And sometimes you need to boost that response a little bit. These don't need it. They don't have that in them, so we don't have to worry about that. Sometimes those adjuvants can cause side effects as well. And all allergens, sometimes things like gelatin are used in making of vaccines. Sometimes things like eggs, like chicken eggs, that can be grown in traditional vaccine production. Those things aren't used here, so you don't have to worry about that if you have a food allergy or something along those lines. The reason I've got the pie down here, I forgot to mention, when we give it a piece up here, we're giving it the crust, right? So we're giving it the outside, the spike proteins. You can think of it like a pie. We're giving it the crust. None of the guts are there. None of the filling is there. Nothing that can replicate is in this vaccine, okay? So it cannot give you COVID. It doesn't have the capability to do that. It doesn't have any of the information to be able to do that. Questions? Okay, we'll keep going. All right, so what about these mRNA vaccines? We know that's a fairly new technology. Is it well researched? Are we guinea pigs? Yes and no, okay? So about 35 years of research has gone into these leading up to these vaccines being made. So both BioNTech, which is the company that Pfizer is working with to develop this vaccine, and Moderna are both companies that focus on mRNA technology to be able to develop vaccines and other types of treatment that are based in RNA. So both of them have experience in that, and they've been working on it for a while. So just giving you some highlights here. So research that was already underway and or completed when the pandemic hit. They've spent years figuring out how to design an mRNA vaccine that would lead to the right protein structure. Turns out you got to make some modifications to the mRNA so that it makes the right protein that the immune system will recognize that matches the virus. So they kind of had a real good progress towards that in about 2013. How to get the mRNA into the cells safely. So how to get it into the cells at all, first of all, right? We have to lose those lipid nanoparticles they figured out, and how to get it in there without the immune system recognizing that itself. So there have been papers published on that between 2005 and 2015, all figuring out the proper makeup of those lipid particles that are really going to work to get it into cells. That was already being done. They've already had a lot of research on similar viruses. So SARS, it was just SARS for a while. Now we've had to add CoV-1 since there's a second one, the one that we're dealing with right now. The original SARS and the MERS viruses, both coronaviruses, both related to this virus, much more deadly, but they didn't spread as well, thankfully. Those outbreaks were in 2005, I believe, and 2012. So they've been working on those with the idea that these coronaviruses, that family, it's given us some nasty viruses for the human population. They've been studying those and trying to figure out how to combat those for a while. And then development of other mRNA vaccines. So they got several papers here on different viruses that have been tested in, the vaccines have been tested in animals and found safe and effective. Several human clinical trials that are in progress, all in phases 1 or 2. I'll share with you on the next slide why this one went really fast. And they're even using these for mRNA vaccines for cancer, and that was developed in the mid-90s and is ongoing. So while this is one of our first mRNA vaccines that's widely being used and approved, at least under emergency authorization right now, there's a lot that led up to this. This is, if you are a believer in providence, like the sisters here at OLLU, this is a case of providence if there ever was one. If this had happened, 5 years before, we would not have these vaccines up and running like we do now. It was really, some of these things just stars aligned, providence was there, and we got lucky, really. Or providence isn't luck if you believe in providence. So. I will note down here, so I gave you several sources down here at the bottom. This is a Nature review article. This is a scientific paper. It cites 222 published papers, and it covers the history of mRNA vaccines and what led up to this. So there's 222 papers there. I can't go through them all, but just know it's a well-researched. Yes, question?
So can you explain to us briefly why scientists had the inkling that an mRNA vaccine might be superior to earlier vaccine technologies?
Yes, and I don't think I have it on here. Yeah, so the question is, why mRNA vaccines? Why do scientists gravitate towards that? Why do they think it's going to be better than other technologies? Several things. One, it's cheaper to produce than the traditional ones. There are just less pieces and less finicky pieces that have to be made. 2, it's very versatile. So mRNA is relatively easy to make in the sequence that you want it, and it's easy to change. So if we find that there's a new variant that our vaccines aren't covering, they can fairly easily, once they know what the variant is and what the changes are, they can fairly easily go in, tweak that mRNA, and have a new vaccine to produce. So it's just extremely versatile for that reason. It's very, it's safer in a way. So there are less components to this. It's just that fat shell and the piece of mRNA. There's no extra virus. There's no other components that we're adding to it. So it just less likely to cause as many adverse effects. You still see some, you're activating the immune system, and we'll get to that in a little bit. But those are a few of the reasons why these are really being sought after. It's really going to make development and production much faster, I think we'll find. Any other questions? Okay, so on that note, this seems really fast, right? Normally vaccine takes several years. Why did we get it so quickly? Is it properly being tested? So yes, no testing corners have been cut. All animal and human studies were properly conducted in the same way that they always are. Okay, so I've given you just a quick outline here. These phases are the human studies. So the first phase is very small number of people testing for safety and side effects and dosages. Second phase, several hundred volunteers, so they're just increasing it. Okay, if phase 1 looks good, let's try it in more people and test the same thing. Here, they may continue testing dosages, or they may hone in to one dosage and stick with that. Phase 3 is the hundreds to thousands of volunteers, and all of these vaccines, 30,000 plus people involved in each one of those studies. Here, they're still testing safety and side effects, but now they're testing efficacy. How good is it at actually doing the job we want it to do? And we'll get into how they calculate that. So all of these were conducted, all of these were submitted to the FDA. They were done in the proper way. So why did it happen so fast? Several reasons that I've listed for you here. One, extreme global urgency. So this was a drop what you're doing, everybody work on this kind of problem, okay? And we really haven't seen that with any of the other vaccines that have been worked on, right? So they're still working on a flu vaccine, but they're working on other things too. This was a drop everything, get it done, everybody working together. People, they published that the genome sequence of the virus as soon as they got it, right? They're sharing information very easily here. Removal of funding issues. So all these studies up here, all these phases, they take lots of money and they take lots of funding. So a lot of times you have to do one study or do one phase, stop and wait to get more funding to do the next one. It wasn't the case for us, or at least for a couple of these, US government was like, here, take our money, just get it done and figure it out. So they didn't have to wait on that funding. It was all there up front, and that makes a huge difference to this too, not waiting on that funding. It allowed animal studies and human studies to happen concurrently. So while they were doing the phase 1 study, they were also doing the animal studies. That's usually not how it works. Usually you do all the animal up front, wait for more funding, then you start the clinical. So they made an exception there. They started both of those at the same time. So that saved a little bit of time. Like I mentioned before, they've already been working on similar viruses. That helped us a lot. This wasn't a brand new out of nowhere virus. It looks and acts similar to some of the others we already knew about. And then lastly, and this is potentially just as important as the funding issue, for the efficacy, which we'll get to in the next question here, they needed a certain number of people to catch the virus to be able to show does it work or does it not work for that efficacy number. And that's really hard to do if your virus is not circulating. So if you try to do a flu vaccine trial in the middle of summer, that's going to take you forever, right? It's going to take you a while to get enough people to actually catch the virus to where you can make that determination. Transmission's running rampant with COVID, not a problem. So they got that data very, very quick because it's spreading like crazy. So that while not ideal, it's helpful for this purpose. Questions? All right. Yeah, I gave you a phone number in the chat, so anybody online, for some reason the chat and the vocal stuff for people online is not working, but you can text that phone number any questions that you have.
Yes. There was also a lot of collaboration, like even among rivals, right?
So the question was, wasn't there a lot of collaboration even among rivals? I think there probably was. I don't know the details of that. But yeah, as far as the global scientist community, yeah, everybody's working together all on the same problem. It really helps a lot. Okay. All right, so is one of the vaccines better than the others? We'll cover this, and this will lead into us talking about how they determine these numbers. Okay, so the short answer is no, not really, okay? We can't compare them completely, and one of the reasons we can't do that is you have to keep in mind the conditions when the trials were completed. So Pfizer and Moderna, we can compare those a little bit better. Similar vaccines, and they did their studies at the same time. So that phase 3 trial was in late summer into fall last year. At that time, there were lower levels comparatively of COVID. There were no or few new variants circulating, and all of that all their volunteers were in the US. Okay, so those you can kind of compare. The Johnson & Johnson, they started their phase 3 trial a little bit later. They started it in fall to winter. At that time, we were headed into that next surge. So there was increasing levels of COVID. There were more circulating variants, at least one or two of the early variants were circulating. And most of their data, their volunteers were collected in Brazil and South Africa, okay? So different times, different levels of COVID circulating, different variants around in different places, okay? So that's why the Pfizer, Moderna, Johnson & Johnson, you can't compare those apples to apples completely. So when they determine efficacy here, Pfizer and Moderna almost identical, and I'll explain to you what those numbers mean here on the next slide. Johnson & Johnson a little lower. That's not something you should be worried about with that vaccine. The reason being, I think a lot of scientists speculate that if those the Pfizer and Moderna studies were run at that same time with the higher levels of COVID and the more variants, we might have seen these numbers a little closer to the Johnson & Johnson, and that might be what we're dealing with now. We don't know that for sure, but that's a possibility. What I want you to pay more attention is this last column. So the idea, the goal is not always to completely get rid of all infection. The bigger goal is how do we prevent people having severe disease that leads to hospitalization and death, right? We would rather make it so you get a cold and it's done, and not that you have lung scarring and severe disease and hospitalization and death. All of these vaccines were fantastic at that. Okay, so Pfizer, Moderna, and Johnson & Johnson, all in extremely high numbers at preventing hospitalization and death, and we still see that now. We'll see that in a few slides. Down here, so these are trial results. We expect those numbers to change a little bit once we get to the real world, and that's just real world. That's just based on sample size, right? So this is 30 to 45,000 people in each. When you look at real world, we're talking now, we've got like something like 166 million in this country. So when you get a bigger sample size, you expect those numbers to fluctuate a little bit, but still very, very good. Depending on which study you look at, there's lots of studies that have been published. A bunch of those are on the CDC website, which I've linked for you here. So it's still very, very good at preventing symptomatic and asymptomatic. It's still very, very good at preventing hospitalization and death. Most of the people that we're seeing in hospitals right now, a majority are unvaccinated. All right, any questions here? All right, so what does that number even mean, that efficacy number? So let me tell you a little bit how they do this study. Like I mentioned before, they have to wait on a certain number of people to get COVID. And that's based on the statistics, which I'm sure if you ask Dr. Bacchia, he could give you a pretty thorough idea of how they would target that number. For these, based on the number of people in these, they were looking for about 170 to 200 people to get COVID, and then they can compare. Then they're comparing the placebo group versus the vaccinated group. I just pulled one of the graphs for you. They all look pretty similar. This is the Pfizer graph. On the bottom here are days after the first dose. And then the curve you're seeing is the incidence curve. So this is telling you how it's progressing, how many people are getting it as we go along. Each one of these little circles here is a person that has gotten COVID. The ones that are darker on this particular graph are ones that had a severe or hospitalized case. So they're comparing these. This is fantastic data. I think the whole scientific community was in awe of this data, because the vaccines, they just work. They work really well. 95% of the COVID cases were in the placebo group. And I'll get to the demographics and because I know Dr. Alvarez had that question for me as well. That's coming up. So 95% of those COVID cases were in this placebo group. You can see it's going right up. And in the vaccinated group, you have much, much lower. So what does that mean for the 95%? What's that mean for you and me? So if the vaccine efficacy is 95% effective, here's the idea. So here's a group of friends, they're hanging out. You've got a friend here that maybe unknowingly has COVID and is spreading the virus without showing symptoms yet. What that means for these two that I've marked as being vaccinated, it means that they are 95% less likely to get sick from that exposure, okay, than the person that is unvaccinated. Now, every person's a little bit differently, so we're using that number based on that trial. It's going to fluctuate a little bit person to person. It also means that that's every encounter you have. So every time you encounter someone that's got COVID and is breathing near you or sneezes in your face or something like that, that's still your 95%. You still got that 5% chance that it might make you sick, okay? So keep that in mind, that consistently being around unvaccinated people without precautions, meaning the masks, that's why us vaccinated folks are still wearing them around, okay? Being around unvaccinated people without precautions will increase your risk, right? Because it's that 5% every time. If that's only happening once a week, okay, there's your once a week exposure. But if you're like me and you have a toddler who can't get vaccinated and has to go to daycare and is getting exposed, that increases your risk, okay? Every time you're around an unvaccinated population like that. Any questions? Let me show you a little bit about demographics. So did they control for population demographics and virus exposure? Yes, it's not fantastic, but they did pretty well on age and sex. Okay, let's say that. So they've got a good amount of the 55 and under and the 64 and older. That's a good amount. And the reason we really want to separate out this 65 to 75 range, and we don't care so much about separating these, is that we know that immunity, your immune system does get weaker as you get older, okay? So that's why they really want to pay attention to these numbers. And of course, about 50-50 male, female. These are Pfizer numbers, by the way. Moderna was very similar. Johnson & Johnson did a little better at getting a larger spread on race. And my guess is that's probably because they did a lot of it in Brazil and South Africa. So they have a little bit better spread there. So here they were representing several different race categories. They're not huge chunks, but they're when you consider how many people they did, they did a decent chunk there of getting people enrolled in that. And I would say with something like a vaccine, I wouldn't expect race to play a huge role in the response. Sometimes different medications, and it can, right? Your genetics plays a role, and that can be represented in your race. But I wouldn't expect that for vaccine quite as much. And then virus exposure. So what if the vaccinated group just sat at home and the placebo group was out and about, and then that's going to skew your data. So the way they control for this is the study is blind. The participants do not know whether they got the placebo or they got the vaccine. Everybody gets a shot, and they even sometimes use another vaccine as the placebo, just so you get some soreness in your arm. So you don't know, right? You truly don't know if you got the vaccine or if you got the placebo. All participants were encouraged to still use masks, to still distance, to still take the proper precautions. And presumably, if they're interested enough to be involved in a vaccine study, they're probably following guidelines, is my guess, okay? So I don't think we have to worry about that. And then additionally, you have, like, okay, well, what if someone in this group was just, didn't care, unmasked, going out to parties, whatever? That's why you have a lot of people, right? A lot of people in the study to hopefully drown out that if you've got a couple outliers that are being a little riskier in their behavior. So that's how we're controlling that's about as good as you can do, right? With humans, we can't lock them all up. We need them to be out and about and exposed so that we know if the vaccine is actually going to work. Any questions? I'm trying to watch my time. I know we got 20 minutes and several more things to get through. Okay, so right now, all of our vaccines are under what's called emergency use authorization by the FDA. We will be expecting at least Pfizer and Moderna, I think, should be coming up on their full approval here probably in the next month. But I know that's been a concern. People are worried about what that means. The short answer between as to what's the difference, it's time. Okay, so we'll get through that. The EUA is it's a faster, streamlined process, and its goal is to get a needed vaccine or medication to the public that is quicker, but doesn't compromise safety standards. So all their safety standards are still the same. That is not compromised. So I separated this out into a little chart for you. So for emergency use authorization, here's what you need to have. They have to prove that there's known and potential benefits to the vaccine that outweigh the known and potential risk. Okay, so they have to provide that information. They must show that the vaccine may be effective, as opposed to the full approval must show substantial effectiveness. There's no doubt here. We already are at the substantial point of effectiveness based on those trial results. They were really good. So that's not a concern in my opinion. They must include all phase 1 and 2 data and phase 3 with up to 2 months or with at least 2 months follow-up. So meaning they stopped their phase 3 trial and then kept following those people for 2 more months before they submitted this EUA. Okay, and that's to continue those safety standards, right? So they're continuing to watch them for side effects. They're continuing to watch them to see if there's anything that they should be concerned about after that. The difference here's where I mentioned time, right? So that's 2 months follow-up. For the full approval, you have to have at least 6 months follow-up. And I believe for the pediatric vaccines, they've asked for 4 to 6 for even the EUA. So they want to make sure that those are safe for the kiddos. They have to submit chemistry. So chemistry meaning like all their processes. How did they make this virus? What molecules are they using? Or vaccine. How do they make this vaccine? What molecules are they using? All their manufacturing controls, quality, consistency. They have to submit all that with the EUI. The full approval, the difference is they just have more of it, right? More detailed, more extensive information. They still have to have site review and inspections for where they're making it and developing it. You have to have more of that for the full approval. So maybe you have to have 1 or 2 here and you have to have half a dozen here, something like that. They must have plans for full approval. So it can't be something that you're just submitting and not planning to apply for full approval. And then for the EUA, they submit all the data in the large report. I know Moderna's was like 55 pages. I think Pfizer's was like 92 that I flipped through. And I linked somewhere in this presentation, I have those all linked for you. And you can get to all of those reports. And then the difference with the full approval, the FDA goes through all that data with the fine-tooth comb. So that can take months for the FDA. So instead of just that large report, they're going to take all of their raw data and they are going to go through it with a fine-tooth comb to really make sure. So in my opinion, EUA is still very stringent in their safety standards, and the efficacy that's shown with these vaccines, there's no question to that. So I don't think there's a big difference, but if that does make a difference to you, the full approval, at least for the Pfizer and Moderna, should be shortly coming here in the next month or so. Any questions there? No, someone? Okay. Okay, what are the side effects and what about long-term effects? So most of you are probably aware, because this has been pretty publicized, like what to expect when you get a vaccine, right? So most are relatively mild, resolve within 24 to 48 hours. So by mild, I mean, you can lay in bed at home and it's going to go away, right? You're not having to go to the doctor. You're not having to go to the ER for the most part. It's going to be a mild thing. Pain at the injection site, fever, fatigue, body aches, headache are some things that you could expect. These are all effects of your immune system working, okay? That said, the severity of side effects doesn't correlate to how well the vaccine is going to work. So if you didn't get any side effects, don't worry, it still works. It's just a difference between some people's immune system responding a little bit differently than others. And then what about the more adverse ones? Okay, so all of these we found to be rare. And we expect these to happen within hours to the immediate months. So within the next couple months after you get the vaccine, that's when you expect these. Vaccines have been around for a long time, okay? So we already know some of the adverse events that could happen, and we know what to look for and to be aware of those. So anaphylaxis, that's, when your throat closes up, you can't breathe. That can occur in people if you have a known severe allergy, really of any type. It's good to check with your doctor. Or you've had a reaction to vaccine before, make sure you check with your doctor before you go get it, okay? But it's still been shown to be rare for this. Guillain-Barré syndrome, this is when the immune system attacks your nerve cells and it'll result in paralysis. Most usually cover, but that's, it's nothing to blink at. That's not going to be pleasant and it's going to be rough. So far, we've seen 100 cases of that in 13 million people receiving the Johnson & Johnson. So still very, very rare, 113 million. You are more likely to actually, it's also a risk, all these actually are also a risk when you get the virus itself, when you get a virus infection. Really, most virus infections all have a risk of these because they're immune responses, right? So you're actually more likely to get that from an actual virus infection than you are to get it from the vaccine itself, based on what we've seen so far. Myocarditis, this was in the news over the summer a little bit in young adults. That's heart inflammation. Most of those resolve with just treatment and rest. 730 cases out of 166 million vaccinated in this country. So still relatively rare, but we are seeing that more so in young adults and a little bit more so in males. Young adult males is where you're seeing that. That's when I would say if you have a known heart condition, check with your doctor first to see if that increases your risk of that. And I'm sure they're really watching this for the pediatric trials as well. Thrombocytopenia, this is a clotting disorder. And it does some funky things, which if you know, when the doctors know what it is, they can treat it fine. If they don't know, it does some funky things with your clotting system, and the treatment can make it worse if they don't know what it is. But now they know to look for it. We've seen 20 cases with Pfizer and Moderna, 15 for Johnson & Johnson's. Those are the most recent numbers I found. And I have all the links for all this on the next slide. I just didn't have room on this slide. So it's still rare. If you have a known clotting issue, if you have a known vascular issue, check with your doctor to see what they think about this. I have a friend that has a clotting disorder, and they waited for quite a while to see what the data were going to show, and she just recently got it and is doing fine. So all of these are possibilities. All of these are very rare. So it's your choice to weigh benefit versus risk, but I would say your chances of getting COVID and possibly being hospitalized are going to be higher than getting any one of these things. And then this last section down here, we see no evidence of these adverse events. So antibody-dependent enhancement. This is when a vaccine makes the infection worse. So if you get a vaccine, but then you get exposed to COVID later and get infected, with antibody-dependent enhancement, that would make that worse. There's only one virus that we know that absolutely does that. It's dengue virus. We don't see any evidence of this here. We see the opposite. Breakthrough infections tend to be much, much milder. And then they also look for COVID-19 disease, right? Do we see any similar? We wouldn't expect it because we're not giving the whole virus in the vaccine, but they look for lung scarring, vascular damage, symptoms of lasting a long time, death, and we have not seen any of that with the vaccines. Okay, questions here? Yes, Marta.
Yes. And I'm sorry for coming in late. I have a male who is in his mid-40s, and he got his first vaccine, Moderna, and he's still experiencing pain, and he can move his arm.
Okay, so
Quickly.
yeah, so Maribel brought up that she knows someone in their 40s, a male, got Moderna, got his first dose, and still experiencing vaccine or pain in his arm. Yes, that's known. So Moderna, I think they're calling it Moderna arm. So something about the Moderna vaccine, and sometimes it'll swell up. It'll look like a big welt almost. So the Moderna vaccine can sometimes give you a big welt on your arm. Generally considered harmless, it will go away. But I would say if it's lasting, longer than, a week or two, you should check with his doctor, and make sure they report that, because they need to catalog all those things. But yeah, that is known as the Moderna vaccine, yeah. Okay, long-term effects. So companies are still following trial participants. I know Pfizer is doing theirs for up to 30 months, just to make sure. We don't expect to see long-term effects, okay? And the reason why we don't expect to see long-term effects, one, we've had vaccines for a long time. We know kind of what to watch for and what to look for. And most of the things you're going to see with a vaccine are going to be days to a couple months after. That's when you're going to see those effects. They don't stay in your body for very long. So when you get the injection, it'll go into the cells right around your muscle and lymph nodes right next to your injection site. That's where the vaccine's going to go. And that's why you get some of that pain in your arm sometimes. Those are the cells that are going to make the spike protein. They're going to alert the immune system, and the rest of those effects, are your immune system doing its job. The mRNA is very fragile, and that's true with the mRNA that your cells naturally make. Okay, it's very fragile. It degrades super easily and very quickly. So that's only going to stay around for hours to days. The spike proteins that get made, those will remain up to a few weeks. There's studies on this, and some of those are linked here below for you. So they've looked for where the vaccine goes. That's where those cells, where it stays, and they'll be up there for up to a few weeks, and then they'll be gone as well. What's left is the memory that your immune system has made and antibodies that it has made. Antibodies are what's going to attach to the virus to help get rid of it should you get exposed again. So we wouldn't expect long-term effects, but they are watching for those. And by the way, you're, again, much more likely to have long-term effects from getting a COVID infection than you are from the vaccine. All right, so how long does the immunity actually last? And will you need a booster? Currently we're in that flux, right? The conditions are changing. So far, we have data out to about 8 months, still all showing vaccine effectiveness to be very good. Remember, we're not just looking at the effectiveness with keeping you from getting it, but we're also looking at, is it keeping you out of the hospital and keeping you from dying? And they're still very, very good at both of those things. We do know that antibodies will wane over time. Okay, the levels of those go up. The memory is still there. You've still got cells that have that memory, but you still might get infected, but just have very, very mild symptoms. So our government just announced boosters to be available for everyone, not just immunocompromised, which was last week. This week, available for everyone here in the fall. Scientific community is still not convinced that the data warrants that yet, that it's needed. What would be more useful is if more unvaccinated people got vaccinated, because that's really what's taxing the healthcare system. Most of the people in the hospitals are unvaccinated people. It's gonna bump all of us that are vaccinated. It's gonna bump our immune system up a little bit better. So yeah, if it's available to you, go ahead and get it. But the other thing that's kind of ethically being debated by World Health Organization is we've got a lot of countries where a lot of people haven't even had it available to get one. It would be more useful to us to have them vaccinated. Reason for that, the longer you have people unvaccinated, the more infections can happen, the more variants you're going to get. Okay, so if we had, right now in this country, I think we're about 50% people vaccinated, and that varies on regions, right, as well. If we had gotten up to 70% last summer, we probably wouldn't be in the Delta situation we're in now. So that's just kind of the nature of it. The variants will keep coming because the virus is able to replicate and able to make more variants. So there are vaccinated people getting COVID right now. I know everybody knows somebody now, right? I'm pretty sure you do. I know at least a few people that are fully vaccinated and have got COVID. What's the point if I'm going to get it anyway? So even though everybody knows somebody at this point, vaccines are still very good. So 1% or less than 1% of 166 million people is still like a million people, right? 1.6 million people. So that's why everybody feels like they know somebody. So here's the data on the breakthrough cases here. So that breakthrough, I mean vaccinated people that have gotten COVID, symptomatic COVID infection, or asymptomatic as well. So right now we have about 166 million people fully vaccinated. Here, this white sliver, that's the number of breakthrough cases we have counted at this point. I expect that number to go up. So that percentage is going to go up, but right now, less than 0.1%, right? And that's with everybody feeling like they know somebody. Like I said, when you've got 166 million people and you take 0.1% of that, it's still a lot of people. And of those 193,000, here's the breakdown of those that are just infected with a mild case. That's here in the blue. Hospitalized is this tiny blue sliver, and then deaths even smaller than that. And there's the actual numbers for you. And about 75% of those in the hospitalized and death category were older individuals. So as sad as that is, that's maybe to be expected a little bit. So still, vaccines are still working very, very well. And if you do get a breakthrough infection, it should be much milder than if you got it otherwise. Right now, our numbers against Delta, it varies a little depending on what studies we look at, but around 88% effective. And again, I've got all your sources here, and 96 against hospitalization. So again, that's really what we're looking at. We're trying to keep people out of the hospital. So it's still working against Delta. There has been some, Israel has had some low results here, okay? So we don't know why they're the kind of the outlier of the other countries that are looking at effectiveness against Delta, but that's part of kind of what spurred on the talk of boosters. All right, any questions? Yes.
Megan, I'm wondering, of those fully vaccinated people, and most of whom are older, is anyone studying to see how many of those folks, were immunocompromised, and so the vaccines actually never really created the same level of immune response? So
the question is, of these people with the breakthrough infections, especially the ones that were older, is anybody studying how many of those were immunocompromised? I'm sure they are. I'm sure there's already probably a breakdown of any other heart disease, diabetes, obesity, if any of those other things. I don't have the numbers right here, but I'm sure they're out there. Okay, we're closing in on it. We're almost to the end here. So do I need a vaccine if I already had COVID? Yes, that would be a great thing to do. So generally, the amount of immunity from infection really varies person to person and varies based on how bad of a case you had. So more severe infection usually equals more antibodies equals more immunity. So if you had a mild cold-like infection, there's no telling how much immunity you got from that. We don't know without somebody testing your antibodies. So vaccines, we do know, because we know how much the spike protein, right, how much we're putting in, much more consistent. So a larger, more consistent immune response, you're going to get from a vaccine. So therefore, you're going to get better protection from that. And there have been studies that have shown that people who had COVID infection, and then they got even just one shot of like Pfizer or Moderna, had an even better level of protection. So they looked at what antibodies they produced, and it was even better than those of us that didn't get COVID yet, but had the vaccine. So highly recommend, even if you already had COVID, you should go ahead and get at least one shot. Immunity from natural COVID infection, especially if you had it way back at the beginning of the pandemic, it may not be as effective against Delta. We don't know. So just hedge your bets there, and hopefully that'll keep you safe. Okay, does the vaccine affect fertility, pregnancy, menstrual cycle, breastfeeding? Okay, all these things have been in the news at some point or another. So I'll go through briefly each of them. No, it does not affect female or male fertility. The reason that kind of rumor came about, a doctor had claimed that the spike protein was similar to the protein that's involved in placenta attachment. So he said, if we're making an antibody to this, it might affect that as well. actual geneticists then went and looked, okay? So you take something like that seriously, people have gone and looked at it, and when you do an alignment of those two proteins, they are not really that similar. And antibodies themselves are very specific, so that's not something we would expect or be concerned about. That said, they are watching people, and they've not found any difference in implantation rates. They've done some studies with people being able to get pregnant post-vaccine. However, COVID-19 infection has been shown to lower sperm counts in men. Okay, so that's the COVID infection, not the vaccine. If you get the full-on virus, it is possible that you could see that effect. Pregnancy. They've looked at this. The rate of miscarriage among pregnant women who receive the vaccine is no different than the rate in the general population. If it wasn't a problem, you would expect that rate to be higher, and we don't see that. COVID infection, however, is more severe in pregnant women that are unvaccinated. They're on CDC's list of vulnerable populations, so keep that in mind. And yes, that is a picture of my daughter, because might as well, right? You're talking about babies. She's about 10 months older now, but I had to stick her in there somewhere. Okay. Does it affect menstrual cycle? Possibly. There have been reports of menstrual cycles being lighter, heavier, timings off, pretty much immediately after someone's gotten the vaccine. Your endometrium is part of your immune system. So there are immune cells that play a role in that lining building and breaking down. Stress, if you're feeling stressed about the whole world basically right now, that can also cause changes. So that data was not collected during trials about menstrual cycle changes. So they are collecting data now to see. It still seems to be rare and probably not something to worry about. Breastfeeding, yes, it's safe to get the vaccine while breastfeeding. The vaccine will not end up in breast milk. They measured this. Your antibodies will. So the immune molecules that your cells are making will go to your breast milk, same as it does if you get flu or cold or something like that. So your baby's going to get protection, and they're not able to get a vaccine. So that's really fantastic for your baby to get protection that way if you're breastfeeding. All right, any questions? Okay, yes.
I just have a quick question about like the chemistry.
Mm-hmm.
You said how mRNA, the stability was not that good. It's very unstable. Is it possible because of the hydroxyl group compared to DNA? I think ribose has a hydroxyl group in the structure, and RNA I think has a hydrogen.
Yeah.
Is it because of that, or?
So Grace is asking a great biochemistry question. She's asking about the stability of RNA. It's partly because it's single-stranded, and yes, it's partly because of the ends. There are enzymes that will just start chewing it from the ends.
Okay.
Yeah.
Thank you.
Yeah. Okay, so on that note, I'm just going to leave you with a few good resources. If anybody has more questions, I'm sure there are plenty more questions. So feel free to ask them now. You can send them to that phone if you would like. You can email me if you would like. If there are a lot more questions that come in, we can all have another one of these little sessions. This is being recorded, so I'm hoping to make it available to you somehow on SharePoint. We'll figure out how to do that. So good resources. There's a ton of information on the CDC site where they've just collected a bunch of studies and a bunch of information. I also have sources, throughout this presentation. We'll get you those slides on SharePoint. If you're like me and you just want something quick, right? Not to have to read through a whole bunch of stuff. These are two people. If you're on Instagram, these are two Instagram accounts that I follow. They're both experts in this field, and they're quick, good information, and they keep you up to date on things that's coming out in the news. So those I would recommend as well. All right, with that, anybody else have questions I can answer for you? Yes.
I want to go back to that Moderna arm.
Mm-hmm.
Can they still get the second vaccine? Because this person got so afraid, and so he just didn't go back for the second dose.
So the question is, Marvel's asking about the person with the Moderna arm. Can they still get the second one? I would imagine so, but if it's lasting that long, he should just go see his doctor. Go see your doctor, and they may even refer you to, you could go see an immunologist if you wanted to, just want to be real sure. And that'll give you the confidence of whether or not don't sit, tell them not to sit in fear. Don't sit at home and work yourself up over it. Go see your doctor and see what they say. If they're a doctor that really dismisses, says, oh yeah, whatever, find a new doctor that'll really pay attention to you and give you a really thoughtful response on what you're experiencing. So.
Thank you.
Yep.
Wait, does it affect, like, if you don't get it at a certain time, like the second dose, you would have to
Oh,
restart?
yeah, wouldn't you have to like redo that?
So they're asking about the dosage. There is a little leeway. I can't remember which it is. With Pfizer and Moderna, the distance between doses is 21 or 28 days, depending on which one it is. There's leeway in that. That's about the middle of what they've tested. So you can go out a little farther and it still be fine. It'll still provide enough of a boost. It won't be too late.
My thinking, and I said I'm not a doctor, go to the doctor, I would advise this person this, okay, and he took the first one, I don't know, in April maybe, and so it's been a few months, and I was thinking maybe you can get the Pfizer now, I don't know, and do the two under Pfizer, I
don't think it would hurt. She's asking about if he got the Moderna, could he, and he didn't get the second shot, could he go get the Pfizer now? I mean, it's not gonna hurt anything. It's just gonna, on that note, when you get a booster, there's not a lot of information about do you get the same one or not. If it's Pfizer or Moderna, I think they're close enough. Either or is probably gonna be fine. Stick with the same one if you're not sure about it. If you got the Johnson & Johnson first, which is just a one dose, they have shown greater effectiveness with Johnson & Johnson plus a Pfizer or Moderna booster. So that would be a good option if you got the Johnson & Johnson first, and then, last year or whenever, and then you got the booster with one of the others.
Thank you.
Yeah, but not the other way around. If you got the Pfizer or Moderna, don't get the Johnson & Johnson booster. It hasn't shown been as effective that way. All right, feel free to go. I don't want to keep you any longer, but if anybody has questions, I am happy to answer them. Folks online, I'm sorry we didn't have the chat working. If you have questions, please shoot me an email and we'll get those answered, or we'll have another session like this and I'll figure out how to make the chat work. This will be recorded. I'll get that to you one way or another through SharePoint.